Welcome. Today I've got with me Ingrid from the University of Edinburgh Hospital. She's a researcher in a rather specialised subject to do with the bladder. So with all of that, I'm now going to let Ingrid introduce herself.
So hi, my name is Ingrid Hoertzauer, and I'm currently working with John Stone and Alan Carson at the University of Edinburgh. And basically, I'm a neurologist, and I did my undergraduate training in Queen's University in Belfast, and then a year of psychology at University College London. And I really became interested in functional neurological disorders through seeing patients on the wards. And I'm really just sort of starting to understand a little bit about sort of patient journey. And what particularly fascinated me was then I found clinically that a lot of people actually had bladder symptoms which hadn't been investigated before, but which could play a really major part in what was part of the most distressing symptoms of their associated with their functional neurological disorder. My area of research really sort of started whenever I went to Queen Square. And what we did was we looked at patients that have got something called Fowler syndrome, which is where there's urinary retention. And we wanted to see how many of these patients had functional neurological disorders. And we found that almost a quarter had a functional neurological disorder, and about 50% of them actually had chronic pain. And these are patients that, as I said, sort of have urinary retention where they're unable to pass urine. And just stop for a brief second here, because as usual, I skipped ahead. I'll tell you a little bit about the different kinds of bladder symptoms that we have. So we've got storage symptoms, which are things like sort of having to pass urine a lot of the time, sort of having to pass urine immediately, sort of needing to pee, and then also whenever you can't quite make it, so being actually incontinent. So those are storage symptoms, and then there are also voiding symptoms. So these are things like where you have to really strain to pee, or where it's sort of stopping and starting, or in fact where you go completely into retention, which is where you just can't pee at all. So those are the sort of storage and voiding symptoms. And what we were particularly interested in was sort of how many patients with functional neurological disorders have voiding symptoms, and particularly sort of urinary retention. And that is because there's a muscle, the external urethral sphincter, which is just the bottom where the bladder kind of outlet comes out to actually pass out the urine, and that is a skeletal muscle. So what can happen is whenever it becomes very tensed up, then the person then can't pee, and we had some examples of that with patients whenever we had the webinar. And also what happens is whenever that sphincter becomes very tensed up, then actually it can send a message back up to the brain as well, which increases up the ability of the bladder to hold another 100 mils or so of urine. I also wrote a book chapter looking at the interaction between bladder disorders and functional neurological disorders. And what I really would say is my research and all the research that is currently out there is really just at the very preliminary stages. So we're really just starting to understand what a big problem this is, and also sort of starting to understand a little more about the kind of symptoms patients have and how much they're affecting their lives. Until recently, there was just one study looking at patients that had functional movement disorders, in fact, any sort of functional neurological disorder, to see how many of them had bladder dysfunction. And they found that 20% of them had bladder symptoms. And we've done something similar where we looked at all the patients coming to the neurology department, and we found that patients that had a functional neurological disorder were significantly more likely to have difficulty with the voiding symptoms, so not being able to pee or difficulty with passing it out or having to strain, than other patients with other neurological disorders. So the major part of my PhD is looking at patients that present with what's called sort of clinical cauda equina syndrome. And what this is bladder, bowel, or sexual dysfunction, which comes on acutely, often accompanied by pain. What I find is that, so we did a retrospective review where I looked back at 277 patients that had presented in this manner. We find that 70% of patients have negative scans, or scans that don't fully explain their symptoms. About half of those patients have got a nerve that's trapped that is certainly probably causing significant pain, but doesn't fully explain their bladder symptoms. And we also find that, so in this group, we find that patients that have got negative or normal scans have a higher rate of functional neurological disorders. And there's also similar rates of bladder dysfunction on follow-up. So what I'm now doing is I'm finishing up looking at a large group of about 200 patients. I saw all of them myself, and about half of them have got this negative scan, and the other half have a disc compressing the nerve roots, which explain the symptoms. So what we're trying to do is look at how many of the patients that have got the negative scan have functional neurological disorder, and how many of those patients have new onset of bladder symptoms, or how many of them have had pre-existing bladder symptoms. It's just a way to kind of drill down and find out a little bit more about bladder symptoms in patients with functional disorders. So that's currently where I am at the minute.
Okay, and interestingly, that that examination of in terms of the research, are you seeing that the strength of the symptoms is the same whether there is a physical cause like a disc pressing, or there's, you know, the scans are clear? Are the symptoms still the same in the way that they present themselves?
Yes, yeah, they really are exactly the same. And actually, I mean, so that there are a lot of very significant and very unpleasant bladder symptoms in the scan negative group. And that's why we're trying to work out what's actually wrong with those patients, because there's obviously something going on, and whether or not it is pain or medication or a functional neurological disorder that's driving this, or in fact, 1 in 3 women have some kind of incontinence. And we want to know just really kind of, is it just that these things are then exacerbated by the pain and by these other kind of things, by things like medications. So we're trying to work out exactly what it is, sort of tease apart the different mechanisms as to why these bladder symptoms happen. But exactly as you said, patients tend to have exactly the same symptoms, whether or not they have a big disc pressing on those nerve roots, or whether in fact their scan is totally normal, or whether they've got a nerve root that is being pressed on.
And we know that there's a higher prevalence of FND symptoms generally within women more so than men. But in the population where you've identified a functional neurological disorder, how's the split between men and women there?
That's a good question. I mean, so I think what I would say as well is there are different splits depending on also what kinds of functional disorders. So things like movement disorders, particularly sort of propriospinal myoclonus and these other kind of things tend to happen more frequently, or as frequently kind of in men and women, but there are certainly things like dissociative seizures and things that happen more commonly in females than males. In our group, what we found is that in looking at the disc population, it's about 50-50 men and female, and looking at the patients that have got that don't have the disc pressing, it's about probably maybe 60 or 70% female to 30 or 40% male.
Okay.
Yeah, so there's slightly higher prevalence, but it's not quite.
Yeah. Yeah. And in the research that you've done, has there been any trend that you're noticing in terms of diagnosis? Because obviously this is not a new situation, particularly for women anyway. And I guess what we've seen is that this is a cross between neurologists, neurology. How easy is it for patients to get a diagnosis where it is relating to FND? Is it generally because they've already been diagnosed with FND, therefore the neurologist is pinpointing and saying, well, your problem with your bladder is down to your FND?
I think we're still at the point where we're not totally sure. So as I said, we're in the sort of preliminary stages of understanding the relationship between bladder dysfunction and functional neurological and FND. And at the moment, I think that patients still need a workup to work out sort of what exactly is going on. So some patients, so you're coughing and sneezing or running and you're finding that you're dribbling urine, and that's probably stress incontinence. And there are excellent sort of physiotherapy guidelines, and also there's a very good NHS app called Squeezy. So if you're interested, please do download that. It's very, very useful. And then 80% of the time, pelvic floor exercises that you can do yourself actually can treat that very well. And there are other things, sort of urge urinary incontinence and these other problems with bladder voiding and just really difficulty peeing and things like that. And often then you need to see a gynecologist or urologist to sort of check that out. My feeling is that I'm hoping that kind of in a few years' time that we'll understand a lot more about this, and that also we'll have kind of the data to back up exactly what's happening. And at the minute, I think that we don't have that. And so probably what's happening is that patients are coming and then being assessed by urology or gynecology or neurology, and then getting a diagnosis that way. Or sometimes, in fact, actually, once you take away some of these high dose of medications, and once you get pain under control, actually sometimes that also allows the bladder to start to function again. And what we think happens is, so we know that in stress incontinence, what happens is that the urethra is lying on the pelvic floor, which is just a muscle, kind of like a sling. And whenever you cough or sneeze, what happens is, so normally the intra-abdominal pressure increases, but the pelvic floor can contract to stop that from falling open and urine coming out. And in someone that's got sort of a weak pelvic floor, what will happen is whenever that pressure increases, the muscles just sort of go down and you lose a little bit of urine. And we think that what's happening in pain then is kind of the opposite of that. So what's happened is if you have very, very bad sort of muscle spasm all the way around your back and down, sometimes to the back of your knees as well, and what you'll find then is sometimes the pelvic floor will actually just be pushing up, so you find it very, very difficult to relax that. And when patients come into hospital, sort of in that I've seen, once we're on top of the pain, then actually then their pelvic floor tends to relax, and then they tend to be able to actually kind of use their bladder again. And the other thing as well is obviously is medications, and I think we'd had a chat about this during the webinar as well. And obviously, so pain is incredibly important to treat in terms of just really allowing people to get on with their lives. But there are some medications, particularly opiates, very high doses of gabapentin and these other, and diazepam, that really, if people are finding that they're having bladder problems, they should just have a think about whether or not their pain is any better on current medications than it was before they started the medications. And if the answer is that the pain is the same now as it was before they started the medications, and they're getting these bladder symptoms potentially from it, and they may also be getting constipation from it, then it's time just to have another think about that. I'm not saying people should rush out and throw everything down the toilet or anything like that. I'm just saying have a think about whether or not these medications are helping you or whether or not you feel just the same. Because some things, particularly as I've said, opiates, high dose gabapentins and diazepam can really affect the bladder. And so we talked about this the last time in terms of just really can be very helpful if you're thinking that those things might be affecting the bladder to go and see your GP. And they're very sensitive, and they can talk you through how to reduce down medications and just see whether or not that affects the bladder as well, and that improves things.
Yeah, I mean, we certainly got some feedback from the webinar last week with people suffering a lot of pain. And obviously controlling pain is a big part of FND, where the medication comes in. But I think one of the key areas of guidance I think that we can possibly give people is where they are experiencing serious pain, then they need to go and see somebody about that, be that a urologist, but go to their GP first of all to get an understanding of what's going on there. Definitely. The other topic that certainly came up was the duration. And we had people who had suffered issues with the bladder for a long period of time, or it had gone away and then was coming back. Has there been anything in the research that you've seen so far that is highlighting any type of trends that would help understand why that would be the case?
Oh, that's an excellent question. I haven't analysed the prospective data well enough to be able to really tease that out yet. In terms of the retrospective data, certainly some people have presented with an episode of urinary retention where they couldn't be at all, and then it's gone away, and then they've re-presented with another episode of urinary retention. And often those things are triggered by pain or surgery or new medications or childbirth, these kind of things. And I think that certainly for some people, there are going to be triggers that will bring back urological symptoms. And I think we're still working to understand exactly what's going on there and why that's developing.
Yeah, and that will be the same for any other symptoms that people will typically experience with FND. The reasons I guess are going to be the same. If the tremors suddenly come back after they've been disappeared for quite some time, there'll be a trigger behind that. I guess it's the same with what you're seeing with the bladder problems.
Yeah.
And the next question that I wanted to put to you was in terms of treatment options. Again, from within our own patient groups, we do know of people that have had quite invasive treatment, catheterization, that is basically permanent because it's the only way that they can have their bladder emptied, which is obviously very distressing as a whole. It's painful. But what have you seen in terms of treatment outcomes or better types of treatment?
Again, I'm afraid to say that we're just really at the preliminary parts of this, and I think to be able to properly treat something, we first need to understand sort of what the scale of it is, and then what we think the mechanisms behind it are, and then we can kind of try to tailor therapy to that. Certainly, biofeedback and urophysiotherapists in the Western have been very helpful in patients that I've seen, but this is still really pretty new territory, and I mean I fully understand patients sort of being very upset by things like catheters and sometimes intermittent self-catheterization can be really quite difficult. And I think the thing is that the urology nurses and the urologists will have dealt with these things for other patients as well. So things like when I did another sort of smaller studies of patients that had got urinary retention, and some of them were telling me that they found almost that they were sort of going to red alert. They didn't necessarily feel panicked, but their heart was beating very fast, they felt very sweaty, they just felt really horrible and unpleasant, kind of there but not there. And sometimes patients felt really panicked with that, and sometimes they just felt really horrible. And actually kind of relaxation techniques and kind of desensitization techniques can be very helpful in those kind of, if that's the kind of reaction that someone's having to catheterize themselves. And like I said, I mean, so we're in touch with the local urophysiotherapist. Actually on Twitter, somebody had contacted me to say that somebody within her local region was working with patients with FND and had really good outcomes. So I'm going to make contact with her and find out what mechanisms they're using as well. And I know that in Queen Square as well, they've been quite keen to try to use other forms of less invasive therapy, kind of like, again, sort of probably mostly focusing on biofeedback and urophysiotherapy and these same sort of types of principles that the physiotherapists working with FND patients are using at the moment.
Yeah. Okay. And I guess a lot of symptoms that are experienced can be dystonic. Obviously, any muscle can be affected by dystonia. It's one of the very common symptoms within FND. I'm guessing that the bladder is going to be no different in that, general dystonia moving around the body could be affecting the bladder as well. Is that something that you picked up on?
Well, so actually, we kind of hit the nail on the head. So actually, that's what we think is potentially happening in people where they can't pee at all. So what we think is that, so it's that skeletal muscle, it's that external urethral sphincter that we think is going into dystonia. So we wonder whether or not that can become almost like a fixed dystonia in some patients. And that's why it's so difficult to, that's why some people end up sort of needing a suprapubic catheter, so put in right actually in the abdomen rather than going in through the urethra. So we wonder whether or not that is what's happening in some patients that have got idiopathic urinary retention, and whether or not they have a fixed dystonia of that external urethral sphincter. And that obviously makes it very difficult to be able to pass urine, and also very difficult to try to relax that muscle enough in order to be able to let sort of flow happen. And so certainly that's certainly one of the main hypotheses about what's going on, really, that whenever people can't pass urine, we think that muscle's going into spasm, and in some people it becomes fully sort of in a fixed dystonic posture then, which is why there's this sort of gripping sensation whenever people are trying to catheterize, and why it can be difficult then to catheterize as well. So that's a separate thing, obviously, from the feeling of it being really unpleasant to catheterize. It's a separate thing if it's actually kind of not going in, or there's this gripping sensation, then that seems more like the muscle itself is going into dystonic spasm.
I know we spoke a lot about, obviously, the urinary side of things, but I guess for other bowel movements, the same difficulties are going to be there. It doesn't seem to be as common within our patient communities. Is that reflected in the research as well?
I haven't even, to be honest, I haven't even looked at the bowel data yet. So I'm afraid I can't say. So I'm just going to say I'm sorry. I'm not sure about that yet, but I have bowel, bladder and sexual dysfunction data, certainly from whenever people were in hospital.
Yeah. Okay, so it's going to be a fairly comprehensive study then.
I hope so. Yeah. I mean, I think there are things that are often embarrassing to talk about, and we tend to sort of shy away from them, and I think also doctors shy away from asking patients about them, and I think oftentimes patients don't want to talk about them because it's embarrassing and it affects how you feel about yourself, but it also can, any of those things can massively change your life and your enjoyment of life. And if you're having to think about where the bathroom is every time you go out and plan your route around town based upon where your bathroom breaks are going to be and things like that, that's a massive impact on life. And having to wear pads or not being able to pass urine, all of those things, they really affect kind of people deeply. And again, the same with bowels. So if you get incredibly constipated and you're very sore, or if you've got any leakage, all of those things, they can just massively affect how you feel about yourself and how easy it is for you to go out and do the things that kind of bring fulfillment and enjoyment to your life. So I think bowel, bladder and sexual function are all just incredibly important things, and I would encourage people to be open about them and just actually I think the more we talk about them, the more we normalize them as part of important parts of our lives, the better that the understanding and the better hopefully that the treatment will be for all of these things.
Yeah, I mean, I think people, like you said, people are generally quite shy about discussing these items. And I know, again, from reading our own patient groups, sex is a very difficult subject when you've got FND, because your relationship is affected anyway. So there's so many things that are playing a part there. And so I'm not aware of really people saying particularly what type of dysfunction they might experience, but I'm guessing that the type of things would be inability to orgasm, or dryness in the case of women, or, you know, the typical sort of they are just sexual dysfunctions that anybody in the population could get, but because you've got FND, you might be more prevalent towards them. So yeah.
Again, yeah. And I think, again, I mean, so we're still, as I said, I'm going to hopefully have good data on that. And then also pain plays a massive part as well in terms of sexual dysfunction. So it can make you not interested in or worried about having sex and these other kind of things. And again, just all, as you said, it massively affects how we feel about ourselves and how our relationships are and all of these things. So let's bring it out into the light and let's talk about it. Let's recognize that it's important. And I know we're all from many of us are from the UK and other places where we might start to blush a little bit, but I think that's the thing. If we all talk about it and just normalize it, then it just makes it easier for not just us, but also the people coming after us.
Absolutely, yeah, and it's taking that fear away from people going, well, you know, it is not me that's, you know, this is part and parcel of having FND. It's just another symptom. So as you say,
and again, and what I would also say, yes, I mean, I don't think we know that yet, and so I would say, you know, there are plenty of reasons to have sexual dysfunction, and I think that it's in the general population, it's pretty terribly talked about. You know, it's just not acknowledged enough, and I think I'm sure in the FND population, it's very similar.
Okay.
So much, Matt. It's as always a total pleasure.